This is Caroline.
This is Maritess.
And this is Laura. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud medical surgical nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
We welcome you to this episode of Med Surg Moments. Our topic today is hospice versus palliative care. But before we get started, let's see what's new with everyone. Caroline, why don't you start?
Well, hi, ladies and our audience out there. Good to hear from you again. My latest update is we started the new year on a wonderful Caribbean cruise and all that goes with it. And within 24 hours of getting back on land, I was sick. The COVID finally got me. So some people out there will say, well, that serves you right for going on a cruise. But we've done several cruises as we've emerged from COVID, and I've been very lucky. But it got me good. So I'm in recovery mode from that right now. So apologies if I sound a little nasal, but there you go. I have a healthy respect for everyone that's been through this. I really do. Other than that, sequestered for 5 days and back at work now and trying to get this new year going. Maritess, what's going on with you? I hope that you're well and healthy.
Caroline, I am so sorry to hear, but I'll tell you, you sound great. So you may probably think that you've got some voice changes right there, but I can tell, you're well. And I'm so happy to hear that you had fun in your cruise and also doing better with your situation right now. Well, my update is more of my kids, and I am very happy to share that they are changing their activities. This is something new to our family. They're starting skating lessons. They've been always doing taekwondo, martial arts, and so this is something different for them. They said, Mommy, no more competitions. This is just having fun. So I wonder if they're turning into a non-competitive type of individual.
That's so nice to hear that they this came from them.
Yes. And they said we're doing this just for fun. So that's my update.
That sounds great. And they have immediate buy-in if it was their suggestion. So good luck with that. That sounds wonderful.
Thank you. How about you, Laura?
Oh, well, I'm going to have to join Caroline's club. I am recovering from COVID as well. Yes, just about a week ago, just on Sunday, my ear wouldn't pop. And I was like, that's really strange. The next morning I woke up and all of the other symptoms hit. And I was like, oh my gosh, what have I gotten into? So took a test and positive. So no fun for me. I stayed in my bedroom. I kicked my husband out and sent him to his man cave for a few days so I could have the whole bed to myself and I could just lay there and rest. And he was a trooper, took great care of me. And then a couple of days later, he came down with it. So,
oh no. Oh my goodness. Well, at least your husband took a test. My husband said, I can still smell. I'm not testing. But I think he's had it as well. My biggest concern is we live with my 86-year-old mother. So we put her in a corner and basically have been very, very separated. So far, so good. She tested negative. So we want it to stay that way. So
good.
Well, feel better, Laura. Definitely.
I will. I am. Better. I'm on the mend. We're both on the mend.
Good. Indeed we are. Yes, indeed we are.
Okay, good. All right. Well, let's move on to our topic. Today's topic is one that I suggested, hospice versus palliative care. And since it's my topic, I thought I'd share with you a little background as to why I chose it. I have always had a knack for taking care of these patients. I've had a big heart. When I was on the floor, comfort care patients in the beginning of my career really, really scared me. But as I started to interact with these patients and their families, I just realized that it came very easy to me to talk to these families and to answer their questions. And I started reading all about it. I started going to webinars and lectures, and I just found that it's a topic that I am very, very, very comfortable with. I think I've mentioned on this podcast before in the past, I still remember the very first patient that I lost. That is a very personal story for me. I'm sure you both have those stories in your arsenal as well that you use. This topic just touches everybody. And what I found through being an educator is a lot of times people get confused when we're trying to talk about hospice care versus palliative care. And while they are very, very similar, I want to be sure that we are explaining the differences. So I wanted to talk about those differences today. So palliative care can happen at any stage of a serious illness. So we can start talking about palliative care from the moment of diagnosis. Palliative care does not mean that we stop curative treatments. Palliative care and hospice care together, they think they're the same thing, and they think, I don't need them until the end, until I'm right about to pass away or till we're ready to stop fighting. And that just couldn't be further from the truth. So I really try to make sure that my learners, my students, nurses that I come in contact with really understand that we can start these conversations way earlier in the game. Hospice care does come near the end. The main difference between palliative care and hospice care is that we have to have a physician that documents the patient only has 6 months left to live. Their prognosis is 6 months or less. And once that doctor documents that in the record, then we can start talking about hospice care. Have either of you had any experiences with those?
So, Laura, first of all, thank you for giving the definitions right from the get-go. I think, like you said, a lot of people, both medical, surgical nurses and lay people, still have a challenge understanding and making a choice as to what they need for their loved ones. My father-in-law, he had emphysema and developed end-stage COPD, and he was in England. And we desperately needed to have a conversation with the healthcare team about end of life, but it came off completely the wrong way. We went in, I think, looking for guidance on hospice and perhaps jumped the gun a little bit, but that was completely misconstrued as wanting to facilitate his death. And I'll never forget the doctor saying to me, "Oh, you're the family from America. Well, we don't practice euthanasia in this country."
Oh, goodness.
I know. I'm like, oh, no, you've got completely the wrong end of the stick here. You know, help us understand, even though we're both medical, what we should be doing to make this transition as easy as possible. What we were missing, of course, was that crucial conversation about the 6-month time frame. So it's so important, I think, that we get the explanations out there and help everyone understand, and also help everyone understand that it's okay to talk about this. It's okay to talk about final months, years and months, and what we can do to help someone move along the conundrum with dignity and respect.
Absolutely. And to recognize that when somebody says palliative care, that does not mean that there's no hope. That does not mean that we have to give up fighting.
Exactly.
And I think that's one of the stories that I can remember when we bring up something like palliative care at the wrong time with the patient, especially when they don't understand what is going on, they can shut off. They will completely shut down. I had a family that said, we are not even going to talk about that right now. We're not going to talk about that. They just refuse to even acknowledge the term. They want to go full force fighting their illness.
Yeah. The misconception, perhaps, from the majority is that if you're not seen to be proactive and aggressive with care, then you are doing your family member or your friend a disservice. And so that's why these conversations are so important, while everyone is still emotionally as intact as they possibly can be and ready to talk about this on as rational level as possible.
Giving the definition to the family members, lay team members, healthcare providers. I mean, this is the foundation, but looking also at why are they having some thoughts of not acknowledging palliative care, not acknowledging hospice care? You know, I noticed, and this is just based on experience, like taking care of patients who are terminally ill patients, most of them would say, I don't want to talk about it. They have a negative attitude towards it. And you're right, Caroline. Why is it that they're not accepting it? They're not acknowledging it. And sometimes they're thinking of the time constraints. I have no time to talk about this. It's either I want to be well or I just want to get it over with. And so it's really very important to share definitions, sharing also experiences from other people. Not sure if you have in your facilities support groups wherein there are ambassadors who actually would talk to family members, patients, and this is usually part of the palliative care team. Instead of the nurse explaining, as I can imagine when you probably were talking to the healthcare provider and this doctor was saying, what are you talking about, right? Instead of a medical provider sharing what they think, finding another person who had a personal experience can make them realize this is really for their own good. Because our main goal, regardless if it's palliative care or if it's hospice care, is we wanted to provide compassionate care to our patients. And I think that's what we need to remember when we are taking care of patients in this category.
Absolutely. And recognizing that when we talk about the different levels of care that we can provide, whether we're going down that hospice path or down the palliative care path, it's all about quality of life for the patient. So if they're in the middle of a treatment, palliative care can just kind of supplement the care that you're getting at the bedside. So not only are we looking at medications to treat your pain or your nausea, but we're also going to be talking about those non-pharmacological interventions, things like massage, bringing things from home, listening to music, and really helping the patient focus on what makes their life full and what brings them joy, and to help patients not forget about enjoying those things while we're going through that process. It's another layer of support for the patient, but it's also another layer of support for the nurses at the bedside. Because not only do you have that primary care team, but now you've got other people that you can call or other people that are going to be asking about that patient and giving you other ideas for making the patient more comfortable.
I think that's an excellent point, Laura. I really do, because while palliative care is aimed to manage symptoms and to enhance comfort and quality of life, it can also be delivered concurrently with aggressive treatments and therapies that are aimed at a cure. And it can be delivered at any stage in a patient's life as well. It's not necessarily associated with old age, I think, if I'm correct. I have a good friend with a son with cystic fibrosis. He would be a good example, I imagine, of palliative care right now. He's still being treated aggressively. He's still responding very well to medications. No one has put a number on his lifespan, but yet he needs constant support, as does his family. And this would be a great example of where palliative care would be very beneficial for him and young adults in similar situations.
Exactly. I know our facility has a palliative care team. So we have a nurse practitioner that's kind of keeping an eye on the medications that are being ordered for that patient, but they're also rounding on the patient in addition to the primary care physician. We've got social workers with backgrounds in palliative care. We have child life specialists for not only if the patient is a child, but also if the patient has children. They can help the family members. They can help the staff at the bedside communicate with that child. Things like music therapy, specialized pharmacists that have taken extra training on palliative care so that they can pitch in a little bit more and help everybody understand that maybe there's different ways to go.
Right. You're making me think about my father-in-law's experience again. And looking back on reflection, I think every single one of us was just kind of waiting for him to take his last breath. If we'd have had some good knowledge about palliative care, whether it was available or not, that remains to be seen. But I think that we could have all had a completely different attitude instead of the woe is us kind of thing and look at him suffering and why can't we facilitate the end kind of thing. We could have looked at it a whole lot differently. Very much a learning moment for me when you look back and think, did we do him a disservice in his final months and years of his life because everyone was just waiting for him to stop breathing when there was so much more we could have done had we have had the support of someone like palliative care. So I think for everyone listening out there, it's important that you understand the differences and think about where it could be utilized for your patients so that you can guide family members who really don't know which way to turn at this moment in time and offer them some tangible support.
Very, very good point. And now I'm switching over to services that hospice care can provide for these patients.
Yes, yeah.
As I said, as long as we have that physician documentation that the patient has the prognosis of 6 months, then they qualify for hospice care. And hospice care can happen anywhere. That can happen at the hospital. That can happen wherever the patient calls home. But one thing I do want people to know is that in different parts of the country, hospice care doesn't necessarily provide a 24-hour caregiver for the patient if they're at the home. It is family members that are taking care of the patient. Because I know sometimes that throws patients, and that does give them a little bit of a negative thought process about it, because it is the family members that are doing a lot of the care at the bedside. Now, they are supported. They have got nurses that they can call. They've got a nurse that will round, sometimes daily, sometimes twice a day. And there are other services that can be provided depending on the means of the patient, like home health aides and things of the sort. But for the most part, it is the family members that are providing that care. And what we're doing is we're letting the patient be the one to guide the care that they want. Patients don't always want to die in the hospital. They want to be at home. They want to be surrounded by their loved ones. They want to be in their own bed. So it may be a sacrifice on our part as a family member to have to take care of the patient. We're doing what's best for the patient. We're doing what the patient wants.
I am so glad that you mentioned that, the services that is part of the hospice care, because palliative care, sometimes it happens within the hospital settings. And when patients and family members are submitting to palliative care, they are still doing treatment. They're still having some therapy with them. Now, what happens is when they go home, and sometimes it settles down and say, you know what, now that I've been given time, 6 months or less, and I'm near dying, that's what happens. They go for hospice care, and then the burden comes in, and the family members would come and say, what do we do? I do have a personal experience with that, with a patient that they weren't ready. This patient has been in palliative care for a while, getting pain management, getting spiritual therapy from different groups, support groups. But then at some point, the physician said, your time is almost up, but the family members are not ready. The patient's not ready either. So they had to go and kind of submit to hospice care, but they cannot decide at all. At some point, he coded in the hospital. The physician talked to the family members and said, we really need to do this. And they said, no, he's still on a full code. We're still going to do this. So
and that's up to the patient.
Yeah, absolutely. So when the patient was able to, because, he can't really submit to a hospice with medications and everything else that's going on, he said, you know what? The doctor said so. If my time is up, then let it be. And it was really hard for the family members. But since the patient was really submitting to it and saying it's going to be fine, he went home with his family and continued with hospice care. I didn't know what happened afterwards, but I think as nurses, it's so important that we understand that journey. We understand how to not just guide the family members, not just guide the patients, but we ourselves to be very cognizant that this is what we need to do. So just wanted to share that because it's so important that we follow what the patient wants.
Absolutely. That's a great message for everybody, Maritess. And as medical surgical nurses who primarily focus perhaps on acute care, it can be a big shift for us to suddenly realize there's nothing that can be done here. Nothing's going to happen in the imminent future, in the short term. And so it's time to discuss palliative care and what that means to a family. Beyond that, then we have to separate the two again and talk about hospice if the time is right. And in acute care, certainly from my experiences, it can happen so quickly that you can't almost believe that the shift in the family. And you saying that, your last comment just made me think about something not too long ago on the floor that I'm working on right now. This little lady was admitted having fallen at home and broken her hip or broken something anyway. But 7 days from being up and independent and ambulatory in her own little assisted living apartment to passing away. I've never seen the decision, to put her through, well, let's put her in palliative care. Let's see if we can get her back to assisted living. And then it was as if the family had this kind of epiphany overnight. And the next morning they said, no, we've decided that she needs to be put in hospice care. She'd just broken a bone. But when you said the patient knows when the time is right and the doctor agreed on the plan, and we stopped all medications except for a low-dose morphine infusion, and less than 24 hours later, the lady passed away. I was so shocked that everything happened so quickly. And so on reflection, it was like, well, that was palliative care, hospice care, all wrapped up in one package. I think they sat and reflected on what had happened to their father and how he had lingered and suffered. And they said, we just don't want this for our mother. Let's just see what happens. And obviously it was her time and there we go. So it was the fastest kind of conversation about palliative care versus hospice that I've ever seen. But ultimately she knew what was going on and passed peacefully. And there we have it. But for me especially, I couldn't believe it. I was making my rounds that morning and I hadn't gotten to the room and the nurse said, oh, don't go in there. She's just passed. I'm like, you're kidding me. How did that happen so quickly? But everything was put in place. They realized nothing was going to come of it. And then there you go. Laura, do you have anything to add to that? Because you sound like you're the expert on this. Is that pretty typical or?
I won't say it's typical. I don't think there is anything typical. I think patients are very, very different. It can go. All we can do is understand each of the different pathways that things might take and explain things to the family. Like it could happen like this, but it could happen completely different. This is what I've seen in the past. This is what you may see. Maritess, you did bring up something else that I wanted to be sure that we brought up when we're talking about hospice, and that is that it can be revoked at any time. If that patient goes home and they're on hospice and things just aren't working, the family can't care for them or the logistics are too much or they're in too much pain, they can revoke hospice and they can be right back in the hospital again if that's what they want to do. Absolutely. It can be revoked at any time. It is truly up to the patient.
Laura, I've seen also patients like after 6 months, they're still there and they're like, I don't want to be in hospice anymore. This is you told me 6 months, but I'm still here. And so I've seen it. So they either come back to the hospital and, do palliative care, but you're like, no, I think I can.
Or the doctor can just write another order that says we have 6 months from now and they can stay on hospice. It is a very fluid thing.
Yes, absolutely. It's very important that during this journey, the patient is experiencing wellness, the quality of life. Yep, that's the most important. And that the family members are enjoying this time. I know it's kind of like ironic to say that you're enjoying your illness, but if you are in hospice and you were given this kind of time, we don't know exactly when that time will be, but make the most out of it. I think that's what's important there.
Yeah. And one thing about palliative care and hospice care is that it can help the family members define what that means for the patient. If quality of life for me means I want to be able to go out on my back porch and listen to the birds, or I want to be able to have my family members come over for a family dinner, or I just want to sit in my rocking chair and listen to a book or have somebody read to me, but it pointedly asks those questions so the patients have an idea of what it means. What does quality of life mean to me? So it helps them identify and quantify what that is. So when we get to that point, our goals can be focused around making those things happen.
Right. I think that's a really important point as well. Do you think as well, and I'm asking you a question because I'm really not the expert here, but do you think that palliative care gives the family time to adjust and to cope with a diagnosis?
Absolutely. There are counseling services that are available through some palliative care companies, not only for the patient, but for the family as well. And hospice provides that as well. Hospice even provides counseling care after the patient has passed away.
Oh, wow. I think that's really important to consider as well, because we get so caught up with our patients with something like this. We have to think about the caregivers, whether they're family or close friends or whatever. We have to bring them into the loop as well. So that's good to know that there's a support out there for sure.
And it's important for nurses, especially med surg nurses, because we do see, I think, a higher number of these patients than some of the other areas of the hospital. Like we know in critical care, patients sometimes just pass away very, very quickly. But on an acute care floor, we're going to deal with these long-term issues. I'm an oncology nurse, so I know all about long-term care, long-term issues. So it's important for med surg nurses to understand all of these pieces. So I encourage you to educate yourself on these. There's LNEC, which is the End of Life Council that does free webinars and free CE units, those kinds of things. Look in your hospital for consortiums and support groups and things like that. But it's important for med surg nurses to educate themselves on these things.
Let me ask you another question on behalf of our listeners as well. How do you handle the situation that 6 months have come and gone and the patient is still with us?
It's got to be an ongoing conversation with the hospice team, with the physician. Because if we get on hospice and a couple of months later, we're not declining as we thought we would decline, we can talk about, well, maybe we don't need to be on hospice. It doesn't mean going back to full treatment. It can if you want to, if there's a good prognosis, but it can mean maybe let's back off on these medications. Maybe we don't need as much as we thought we did. Because like I said, once you get to the end of that 6-month mark, if you're still around, it's not like, okay, well, we're done. Hospice is going to go away. No, they're going to stay with you. We're going to talk to the doctor. It's like, well, now let's just write a new order that we're 6 months from this point, and then you can continue.
Gotcha. Okay. Very good.
And again, being on hospice means you've got access to that hospice team. You don't necessarily have to go to the hospital or to the doctor for your visits. The nurse is going to come to you. They're going to come bring that doctor visit to you. It just gives a lot more support, and it keeps you at home rather than going to the hospital. A lot of times when your pain is just out of control and you end up back in the hospital, and sometimes you're there for a lot longer than you need to be. When all you need to do is you need to come in, you get your pain under control, and then you can go back home. Hospice gives you the support that you need to do that. Because we keep patients in the hospital a lot longer than we need to sometimes.
Well, there's a whole different conversation there, but absolutely we want to keep these patients out of our facilities as much as possible for various reasons. But
unless they absolutely need to be in the hospital, they're gonna do much better at home, surrounded by their families.
Exactly. Yeah.
I'm listening and I'm writing down all that she said, like especially the CE credits. I want to learn more about that. Definitely.
Yes. There's so much out there. There's so much out there around palliative care and hospice, and it's so important. And it doesn't just affect us. I mean, I have done this lecture at a community center with just people in the community who had questions about it. I just went as a nurse with the experience that I had, and they just asked me questions. And the most important thing is to not wait to have these conversations. Every single one of our listeners can have this conversation with their family right now.
I agree wholeheartedly. I've got my 86-year-old mother downstairs. We know exactly what's going to happen when the time comes for her to move on. And I think that those conversations are important to have.
They're very, very, very important to have. I was at dinner one night. We were at an outdoor eatery and a couple sat down with us. So we just started chatting. And I don't know how we got on the subject of hospice care, but we got on the subject of hospice care. And I recommended this website. It is called theconversationproject.com. It's a free website that just has resources. It's got almost like a workbook to prepare you to have this conversation. It asks all of those questions we talked about, like helping you identify what quality of life means to you. It digs deep into what matters most to you. So there's workbooks there for you to make those decisions for yourself and ways to have those conversations with your loved ones. Believe it or not, we are almost out of time, but let's go ahead and summarize what we've talked about today. So we talked about palliative care and the fact that it can happen at any stage of a serious illness. And most importantly, that choosing palliative care does not mean that you are stopping your curative measures. You can still completely fight your disease with whatever arsenal your physician comes up with while you're still taking advantage of these palliative care resources. Palliative care helps us look beyond the pharmacological measures for treating the disease. We're looking at non-pharmacological interventions like music therapy, spiritual care, things to provide quality of life. Palliative care can happen both in the hospital and at home, depending on the services that are available through your means. We also talked about how it's different from hospice care. Hospice care is truly at the end of life when we have a doctor that has written a diagnosis of 6 months or less. We are no longer searching for a cure to our disease. Hospice care can happen anywhere. It can happen at home, can happen at the hospital, wherever the patient calls home. Hospice care at home doesn't always mean that there will be someone available 24/7 to provide care for these patients. Hospice care can also include things like nursing support, home health care, counseling for patients and family members. But it gives the patients an opportunity to spend quality time in their home with their family members. And always remember that hospice can be revoked at any time. It is truly up to the patient. We also want to make sure that Med Surg nurses take the time to educate themselves about this very, very, very important topic.
Great points, Laura. Thanks for that summary. It was a great conversation.
Absolutely great.
Well, thank you all for joining us. We'll see you next time.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
I'd also like to remind you to become a member at AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag MedSurgMoments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Caroline.
Laura.
And this is Maritess. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that makes a huge difference.